So, we will discuss now some of the other views that we haven't discussed. So we'll try to tackle subcostal, but I decided that before we go on for subcostal, just so that I don't lose these concepts forever, I wanted to briefly talk about what we call deformation analysis. What is deformation? It means exactly the word that it means. It's to analyze the deformation of the myocardium, and you can analyze the deformation of the myocardium in any planes and of any structure that actually moves in time. Okay. So speckle tracking echo is a technique to evaluate what we call the strain. Okay. Strain is a very easy principle. It was actually designed by it's not design, it's a property of materials, and it's something that is used to study, for example, contraction or expansion related to like temperature changes. So for example, if you have a bridge and your bridge might become contracted, like the material during very big winters, or might dilate if you're in an area that is extremely hot, you need to understand these properties of the material to make sure the material is not going to crack, that it's going to, how long it's going to resist, is it going, what other types of material like sealants and things like that you need to put. So you can use property of material to understand what strain means. So for example, I'll give you the sense of like a bridge. Let's say you have a bridge that is 100 meters, and during periods of extreme cold, the bridge becomes 90 centimeters. So the idea is that it has contracted by 10%, right? Because it's 100 minus 90 divided by 100. So it contracted by 10%. That's exactly what strain is. Strain is actually how much did it contract or how much did it expand. Okay. And so technically you can do strain on a line. So you can take the actual periphery of a ventricle and then see at the peak of at the peak of diastole when it's completely expanded, what's this periphery? So let's say the periphery is 100 centimeter. And then you take the periphery when it's completely contracted at the peak of systole, it's going to be 90 centimeter. What's your strain? It's 10%. That's basically what strain is. But we know the left ventricle is not like, it's not a U. That's not the reality. We live in a 3D world, and the left ventricle is a cavity. It's like a 3D space. So actually, when you're looking at one single cut and you're looking at how much this contracted from a longitudinal perspective, we're going to look at what's the peak of the change in systole longitudinally. And so we talk about the peak longitudinal strain. So we say longitudinally, okay, it contracted and the periphery reduced by 10%. So we say the peak longitudinal strain is 10%. Now, if you add different uh, planes of imaging, you can actually try to get not just a periphery, but an area. So an area of the cavity. So I'm going to open my website for 2 seconds to show you what I mean. Okay. And if you're interested to read more on strain and understand better strain, you can go and we're going to have sessions anyway on that. So you'll be able to expand your knowledge. But there is a whole section about what we call strain, which is under the TN echo. You just have to go to 2D, 3D strain. And so what you do in strain is that you don't just do the 4-chamber view, you actually do the cut in the 3-chamber view or the 5-chamber view. I mean, you should use what we call the 3-chamber view, which is basically like an apical parasternal long axis, basically like almost. So you have the septal wall, the aorta area or LVOT area, and the side that's free wall, and then you do the 2-chamber view as well. So when you put these 3 axes together, when you put the 4-chamber, the 2-chamber, and the 3-chamber, you don't just get one longitudinal plane, you actually get the second longitudinal plane and then the third longitudinal plane. Okay. And so if you're putting these 3 longitudinal plane together, so the 2-chamber, the 4-chamber, the 3-chamber, okay, the software is able to recreate an approximate of not just peripheries, but actually a surface. Does that make sense? And this time, instead of doing, well, this periphery became this periphery, it's doing the contrary. It's doing this surface, like 100 centimeter square, became 90 centimeter square. And so my peak longitudinal strain is still 10%, but instead of talking about a peak longitudinal strain, we talk about a peak global longitudinal strain. Why global? Because it took into account all these three planes to reconstruct the entirety of the left ventricle. So that's the difference in the terminology when you talk about a peak longitudinal strain versus a peak global longitudinal strain. The global implies that you were able to get the imaging planes on all the axes so that you were able to reconstruct the surface of the left ventricle, the tapissage. So it's not just in a single area that you're looking how big and how small it's becoming. Okay, so you can get the peak longitudinal strain, or you could get a peak global. The peak global will give you much more information, but for that, you need to have the three views. And you need to obtain them sequentially. Why? Because you don't want your loading condition to change in an extreme fashion. The best way of obtaining a peak global is probably by doing a 3D, because then you're able to actually, under the same loading condition, get all of these views together and really get the full surface. Okay, and then you can get a global longitudinal strain. Longitudinal is on the longitudinal axis. Circumferential is on the circumferential axis. So what does it mean? It's the circumference. So this time you're looking from on top and you're looking on how big it was in diastole compared to how small it was in systole. And so what was the circumference in diastole was the circumference in systole. And it provides you this global circumferential strain. Okay. So when we talk about speckle tracking, it's just the technique to measure these things. So the software will take like the pixels of the image and will actually track it throughout the cardiac cycle. Okay, so it will track from the old to the new location, and it actually calculate these distances and provides you with the strain, which is, as I said, the difference in the length compared to the length at time zero. So length at time zero minus length at peak of systole divided by length at time zero, which is the initial status of the ventricle. So typically, by convention, you speak about a negative strain in systole when it's longitudinal because you get shorter. You talk about a negative strain circumferentially because it gets shorter. And you talk about a positive strain in systole for the radial axis. What's the radial axis? It's the thickening of the muscle. How much did it thicken? So because in systole it becomes bigger, it's not becoming shorter, it's a positive value compared to when you get shorter, it's a negative value. So typically the radial strain, oh, sorry, I'm not sharing the right image. The radial strain, it's that thickening of the muscle here in the short axis view. So in systole, you get more thick, so it's a positive value. So that's an example where I did the 4-chamber, the 3-chamber, and the 2-chamber, and we followed how the strain goes, and it provides you with a global longitudinal strain. Okay. You can also apply this concept to the right ventricle, but in the right ventricle, we'll typically only do the 4-chamber view. So you get a peak longitudinal strain because you don't get like all these axes of the RV because it's more difficult to kind of reproduce from a 3D perspective, unless you do a 3D echo. Okay. So that's an example when you do it in short axis, so you can assess the thickening of the myocardium as well. And so you can get many metrics to understand more the mechanics of the ventricles, but you can also apply these techniques to other views. For example, more and more, especially in the adult world, they'll look at what we call atrial strain. So if you want to see like example of atrial strains, you can also do the atrial strain and obtain indices of atrial function. Okay. One of the last thing I want to mention is that strain is the property of shortening or thickening. Strain rate, it's the speed at which this occurs. So when you look at some of these softwares providing you deformational information, you'll get typically dimensional information from what it's able to kind of generate from the algorithms. So diastolic volume, systolic volume, a length, the diameter at the base in diastole, in systole, the diameter at the base diastole, the length in diastole, the length in systole. So it provides you some of these dimensional information. It provides you deformational information, and it provides you also with the speed at which this deformation occur. So we often talk about a strain in percentage for the exact reason I told you. 100 minus 90 divided by 100 gives you like 10% of strain. So it's a percent. Okay. But if you're looking at the speed at which it occurs, we talk about a strain rate, okay? We talk about the units are often 1 per second because it's like percent versus percent in heart rate, which is in seconds. So the unit is 1 per second. And then you'll see that in systole, you get a negative velocity because this time it's a speed at which it occurs. And then during the re-expansion phase, you'll often get these eon A waves the same way because in diastole, you get an early phase where you get a speed of re-expansion and then a second speed during the atrial kick. So you see this E and this A that appears here. So you can also get diastolic information out of these curves. And why there's many curves is that typically by convention, the machine will divide the ventricle in segments, the same segments that are typically used for the what we call the bull eye, which is what the American Society of Echo has established. So typically you have your three divisions, so the anterior posterior, the laterals, anterior septal, inferior lateral. So you get all these like kind of three segments, 1, 2, and 3. And then you get at the apex, the mid cavity, or the base where the mitral valve attaches. So it's dividing into these three areas, septum number 1, septum number 2, septum number 3, lateral wall number 1, number 2, number 3. So that's why you have 6 segments. And so the machine will track the behavior of these predefined segments and provide you the corresponding curve. So you'll have 6 curve. Plus, you'll typically have what we call an average curve, which will average all these segments together. So the white line is actually your average curve of all of these different curves superimposed. So it will actually do an average at every single dot. So it takes, what's happening here, it does the entire average and gives you the white line. Okay. And so we often look at the average, but some patients may have really like one segment that has a problem. So think about those that have like coronary artery disease or arrhythmias or things like that. Maybe one segment is actually not contracting, or maybe one segment is contracting when all the other ones are actually relaxing. We call this dyssynchrony. So with conventional markers of function, like ejection fraction, you just look at the peak systole, peak diastole, and it's like 2 time points. And you don't know if some of these areas have contracted or not contracted, participated to the contraction or not. So strain sometimes can give you more like subtle information of the behavior of the myocardium. So it's often used in these diseases like cardiomyopathy, arrhythmias, or research, patients who had like chemotherapy. So there's a lot of like literature on that, or those with like heart failure related to like coronary artery disease or ischemic heart disease, things like this. But more and more it's used in neonates and TNECO world to understand the mechanics of some of the heart diseases. And now it's used also in the fetal life. So that's just to give you a brief overview of like what strain is and how you can apply this technology to go like really down the rabbit hole of understanding like a lot of the mechanics of the heart in different conditions in both 2D and 3D plane. Okay, subcostal view. It says it's in the subcostal region. So the costal margin is like a really long margin. We often will put the probe at the subxiphoid area. So sometimes it's called the subxiphoid view. But actually in newborn, the true position of a good subcostal view is actually often a bit more to the right side because you're using your liver echogenicity to provide you better echogenicity of the heart. And you're actually angulating a bit your probe towards the area where the heart is. So it's a great view because let's say your heart is really misplaced in your cavity, in your thoracic cavity, like for example in CDH, or if you have like dextrocardia or mesocardia, like if you have changes in the axis of your heart, you can adjust using the subcostal view because you'll typically get nice windows thanks to the liver that is quite echogenic. The problem with the subcostal view is that obviously sometimes you have to press a bit on the belly, which can be poorly tolerated by some babies that are very unstable. So it's not, it's a view to consider, if once you get good scanning skills. But to start with, I know many cardiologists who will start with it because you get most of your info. But if, let's say, you have a baby that's doing relatively well and is wide awake and will be screaming if you put something on their belly, and you're doing a TNE for, I don't know, line placement or, pH screening, things like that, maybe it's not the first view you want to go like bang because you're going to, have your baby screaming and maybe a bit unhappy. So it depends the context, but I know that in many protocols, it's the first view because you get just so much information out of the subcostal. You can pretty much get all the information almost from the subcostal. Sometimes it's more difficult to like look well at the arch, but it's still it's a very good view where you get like a lot of Doppler information. So it is a view where you're going to see your IVC connecting to your right atrium to make sure that it's not a heterotaxic syndrome and that you have an interrupted IVC. So I highly recommend you go on the website. There's actually a case of heterotaxia, and you can see how the azygos runs parallel to the aorta and eventually comes in the chest when there's an interrupted IVC. And then you can also get your descending aorta along the spine, and you can often see your celiac artery and your superior mesenteric artery. So we often talk about what we call the long axis view, the short axis view, or some people call it the coronal, the sagittal. I like to call it the long and the short axis, and you'll see why. It's because we're cutting the left ventricle along its long axis or along its short axis. So this is the actual probe orientation for what we call the short axis. To get what we call the situs, often you'll have to verticalize your probe, and it's almost a 90-degree to the abdomen and chest. And really, it's this one for this view where you get your descending aorta and IVC on the right side of the descending aorta. It's typically something you'll do more vertical and closer to the center midline of the patient. And then from this view, you can also rotate 90-degree and get your descending aorta like longitudinally once you've identified the descending aorta. So since your descending aorta is in the middle of your probe, you can just turn 90-degree and you're going to get the longitudinal view. And you can slide closer to the right side or the liver, so closer to where the probe is, and then eventually get your nice IVC view connected to the right atrium. Okay. If you turn 90-degree from that, so basically in the view of the longitudinal aorta, so the cursor down to the foot, and then you slide towards your apex, so towards your left chest, you're going to start looking at the LV short axis, and that's why we call it a short axis view. Okay. So in this view, you get to see nicely your bicaval view, so your SVC, IVC right atrium. So it's a nice view to see, for example, PICC lines, cannulas, lines that are coming into the IVC, making sure you don't have a line in your right atrium. And of course, you need to do a little sweep to make sure you see the tip of your line. And sometimes be careful because you can get images of superimposition where you think your line is like at a particular place, but actually when you scan from multiple views, you realize that this was just an image of composition from different planes. You can get to see nicely your RV outflow track with your pulmonary valve. So it's a good view to see your RA, RV, and eventually PA. It's a great view for that. And you can see, your short axis. So if you don't have a nice parasternal short axis view, it's a place to kind of assess your mid capillary and septal flattening or septal bowing or septal position. This is a mistake. It's not short. It's long axis. Piscini had prepared the slide. I thought I had corrected it, but should read long. But basically, in this view, you often nicely see the right and left atrium with their interatrial shunt if there is one. And why is it called a long axis? It's because you see the LV and you can see the LV to aorta continuation. And you can also eventually, as you go more anteriorly, see the RV to RVOT to pulmonary artery. So subcostal long axis is what we just discussed. Okay, so if we look at images, it looks like this. So this is a situs view. We can see the aorta is positioned central. The spine is kind of here. Typically, your aorta will be to the left of your spine. It doesn't rule out completely a right-sided aorta, like a right-sided arch. So you still need to do your branching. And part of the reason is that you can have right-sided arch that eventually will also travel after the diaphragm towards the left side of the spine. But it's a good indicator most of the time that, most likely you're facing a left-sided aorta, but you still need to kind of do your branching. If you're in cardiology, for example, in our TNE world, it's often we'll get a structural assessment by cardiology first. So these are things that they will check regardless. And then you'll have IVC, which you see running in the middle of the liver. But what's important is to actually see eventually that IVC connect to the right atrium. So it's important to put color and to do the tracking. I don't think we see it nicely completely in this view. You can kind of appreciate here that the IVC is coming here. And then eventually your IVC connects with some of the subhepatic veins and eventually connect to this right atrium, which is here and sitting on the liver. And as you go here, you go more interior and you start seeing your left ventricle connecting to your aorta, which is here. And as you see the aortic valve opening and closing, so you see nicely the aortic valve, you can start seeing appearing this tricuspid valve, which has a septal leaflet. So the leaflet you can see here, it's going to attach to your septum. And then you can see more of the body of the right ventricle, which is a great place to get a sense of how much this RV is contracting. So you can see here the walls of the RV, and you can see diastole when it's fully open and systole when it's completely contracting. So it gives you a good sense of RV function. And then you see even the outflow tract of the RV kind of is in this area. It's a good place also to see, is there a big pleural effusion? We don't see here. And you can even put your probe and look here, is there another pleural effusion on the left side of the patient? And is there a pericardial effusion at the level of the pericardial sac? So that's your sweep, the full sweep. I don't know if you noticed the RVOT. This is the RVOT. We can see it here. Whoop. Here, you see the valve on top? Laurence, do you see it?
So, sorry, I was muted. Yes, I can see it. Thank you.
Perfect. So it's a good view because if you're like concerned about RVOT obstruction or is there pulmonary insufficiency and you couldn't get a nice angle for insufflation, sometimes your angle is going to be from here. You put color and actually you're almost like parallel completely to your valve and your RVOT. So it could be a good view sometimes to get like a continuous wave Doppler or even a pulse wave Doppler. So here's by color where we see the color flow. So if we go slowly, I'm putting color, I see all those veins at low Nyquist because it's a venous flow collecting together with the IVC and then going into the right atrium. I even see some of the pulmonary veins kind of joining into your left atrium. So that's why it's often a good view to rule out, is there a pulmonary venous disease like, total anomalous pulmonary venous return? Because if we have a patient with what looks to be a PPHN, the first thing you want to rule out is TAPVR. You never want to miss this. So if these patients have not been seen yet by cardiology, you're in the middle of the night, you see there's a right to left shunt at your interatrial level, it's like your first thing. If there's one thing you can remember from this talk, is you have a right to left shunt at your atrial level, you always need to your first thing to rule out is TAPVR beyond anything else. Like your first thing, you do subcostal, you see right to left completely atrial shunt, you need to rule out TAPVR. Like that's your goal from this echo. And then you figure out the rest. Okay. So we can see like pulmonary venous flow coming. And then here, that's the PFO. And then we look, it's a good place because you're well aligned to see, well, is there a shunt through this PFO? Is there like a bit of a red flash or blue flash? And then here you can see even the SVC coming in and filling the right atrium. And as we do these sweeps, we can appreciate sometimes maybe there's a bit of color that's crossing the interatrial septum. Now you're already at the outflow tract, so you're not going to see the interatrial septum anymore, but you can see that there's a bit of aortic insufficiency. Yeah, we can see it here, this little blip. It's normal to have this, physiological. It's not a big jet. Okay. This is in 2D, so you can measure the actual PFO. So we say that, if you're less than 4 millimeter, it's typically a PFO. We can even see the SVC in 2D. So it's a place where you could measure its diameter. If you're concerned about kind of vein of Galen malformation, you would see torrential flow here. But this is the SVC, okay, and would be dilated in some of the cerebral AVMs. It's also where some researchers will measure SVC flow. They'll measure the diameter, they'll do a VTI of the SVC Doppler, and they use that to do SVC flow. It's not something we do typically in our lab, but or in our TNEs, but in Australia, it's been something they've published a lot about because it's basically all the preductal flow to the brain, right? Here we can see that there's a little connection by PFO. And this is what we call the TET view that you can also do in the subcostal, which you get the RVOT here. So that's a nice view for, seeing the RVOT. And you can see that IVC connect to the right atrium. Okay. Okay, we saw all of this. This is another sweep. I'm not going to get again. This is an example of when you measure the SVC diameter. So that's an example of the SVC diameter, another example of SVC diameter, another example of SVC diameter. And then you can do a VTI. This is the VTI in the short axis view, actually, in your bicaval view. And I'm getting a VTI, and I get the VTI throughout one cardiac cycle. So I do a pulse wave Doppler, and I trace the VTI, and it gives me a VTI. So you can use that and apply it in the same formula as the cardiac output to get your SVC flow. It's not something we do very commonly. That's another example where I do a pulse wave Doppler, and I see the characteristic kind of waves of the Doppler and the SVC. And this is the kind of SVC flow. This is a particular important view. I just want you to pay attention. There's one thing that I want you to kind of read on or discuss when you're in your cardiology blocks. There's pulmonary veins that are here, okay? And there's one ASD defect that is very hard to diagnose. It's called a sinus venosus defect. And you can get a superior or inferior one. And basically, it's when you have a pulmonary vein, either a superior or inferior, that unroofs into an SVC or an IVC. And these patients, functionally, it's like they have like a left to right shunt because their pulmonary vein, who's supposed to connect to the left atrium, actually connects to the SVC and drains into the right atrium. And these patients, they behave like ASDs. So how would it look like? One of the best places to see it is that you'll see a flow connecting this little pulmonary vein to eventually your SVC. So it's a good habit when you're looking at your SVC color to make sure that you don't see a lot of flow connecting between your little pulmonary vein here in cross section and your SVC. Here we see the SVC is nicely and there's no kind of red coming in. That's an example of another VTI, but this time we're taking it from the long axis view. Okay, so the bicaval view. This is the bicaval view with the SVC. You have the IVC, which is nice and small. It's actually changing with variations of breathing. You see your right atrium. It looks like a Mickey Mouse. You see the tricuspid valve here. Here you have the left atrium. So it's another place you can see kind of a blip of red. This blip of red tells you there might be a little PFO. If I freeze it, do you see the little blip? Okay, so that's another place to sometimes see your PFO. And it's another place that they will use, the cardiologist, to measure intraatrial shunt, especially when they're going to have to see if there's enough space for them to put kind of an umbrella or prosthesis to close an ASD. So they'll have to get all these views to look at all the rims and see if you have enough material to actually, first of all, to see how big is the ASD, and second, to see if there's enough place to be warranting like a calf closure, because if you don't have enough rim, the prosthesis is never going to be able to hold correctly. Okay. You can see your SVC, you can see one of the pulmonary veins, you can see your IVC. And this particular view, the bicaval view, is a good one to assess your SVC IVC flow, to put color, to see line placements. Also, like your IVC, if you have a kid where your IVC is completely collapsed all the time, it could be for a few reasons. Or number one, his right ventricle is extremely compliant and it's able to empty the entire right atrium into the RV. Okay. Number two, if you have concern for preload, if your IVC is completely collapsed, okay, it could be a sign that the baby is underfilled. So that could give you a sense maybe the baby needs a bit of fluid. But if the IVC is well opened, okay, it just means that the RA pressure is a bit, 4 to 6 about, so within normal limit. But that could also be because the baby is intubated on mechanical ventilation and is exposed to high intrathoracic pressures. So then your your RA pressure could be slightly elevated, and your IVC might still be a bit juicy. While if your kid has neck and septic shock, maybe your kid still needs slightly a bit of filling. So it doesn't preclude you from giving or trying a bit of bolus in this patient. We used to give 10 cc per kilo. Sometimes in some of these patients, I would be a bit more, careful and give a 5 cc per kilo. If I see they have low platelets, low PRBC, and anyways, they're going to need a bit of blood products, That's what I would prioritize instead of like a kind of empty fluid with NS, depending on the clinical status. The other thing I want to mention is the you know, the IVC caliber is often used in like the emergency room literature or the POCUS literature. In the newborn, because these babies have just underwent a transitional physiology and their RV has been the dominant ventricle, the RV is often still a bit stiff, naturally stiff. So your IVC may still be nicely opened up and it doesn't mean as much regarding fluid status. So it's more of a marker you'll use for like a late onset situation. For example, a kid who's like having a neck at 3 weeks of age or late onset sepsis, things like that. Early on in the first few days or the first 24 hours, it doesn't mean much. So it's not like a baby that I would go do an echo and like based on that, I'll decide if I give fluid or not. It's not as well kind of validated, I would say. So this is the other axis, is the famous short axis. So we'll start from completely on the right side. You have the liver here. You have kind of the spine in the back. And it's a good view to see your pericardial sac and make sure you don't have any. So you can even see kind of the pericardium here. And as I go and angulate more towards the left side, so here I had my kind of big bicaval view. So you see nicely your SVC, you see a pulmonary vein, you see kind of your IVC entering in your right atrium, you start seeing a bit of your tricuspid valve. And as you're here, this is tricuspid valve material. And you see it open and close. And now as you sweep, you start seeing your aorta coming off here. And you even see a bit of your right pulmonary artery. And eventually you see your RV outflow tract here. And you start seeing a bit your pulmonary valve. And now you see nicely your pulmonary valve. Pulmonary valve closed, pulmonary valve open, pulmonary valve closed, pulmonary valve open. So you can see nicely that there's no obstruction. The infundibulum is wide open. There's no anterior malalignment or TOF or signs that there could be something blocking the RV tract. You can see the walls. You can see if there is a bit of hypertrophy or not. And as you're going like this, now you see your mitral valve. So what's very powerful of this view is now I can appreciate, do I have a very round septum at the peak of systole, and I can even see my mid-papillary muscle. And I can appreciate that the circumferential contraction looks very good, at least subjectively. And as I go like this, I see a little LV tendon. It's not the muscle, so it's not the moderator band. And I can go up to the apex. So that's the apex of my heart. So I see my nice apex. I see I have an RV and LV apex. And now I could go back towards the other side and redo my sweep. This time with color. So I see the aorta and eventually I see my RVOT. And it's a good place to also see, is there a little VSD? And in this particular patient, we can appreciate there's a little flow here and you can see it cross a bit the septum and it's creating turbulence. You can see it here. Okay. So you detected that this baby has a, little muscular trabecular VSD. You can even Doppler it, although here you would not be aligned with the jet because the jet is going like kind of in this direction and your cursor is this way. So you would probably want to use another view to Doppler this VSD. Okay, so the interatrial shunt provides you great information. It provides you information about the compliance of the underlying ventricles. So if it's completely left to right, it tells you the LA pressure in general is higher than the RA pressure. If it's bidirectional, it's kind of equivalent, RA LA pressure. And if it's completely right to left, it's because the right atrium has a bit of a higher pressure than the left atrium. And typically this reflects what is downstream to the compliance of the ventricle. So most babies in the first day of life will have a bit of a bidirectional PFO. Why? Because the RV has been dominant and it's still a bit hypertrophied. And so the RV and diastolic pressure are similar to the LV and diastolic pressure. So it's not unusual to have this right to left shunt. Also, the PVR are currently dropping. So the pulmonary blood flow is progressively increasing. And eventually you get more LA filling and reversal of that shunt where you get complete left to right shunt, especially if the PD is still open and it shunts completely left to right, then you get a bit more QPQS, then your LA gets a bit more filled. And because of that, it will close the flap of that PFO. And eventually this flap will completely fuse. But we know that 20 to 25% of the population will keep will keep a bit of a shunt. And so obviously, if you have tricuspid stenosis or tricuspid atresia, then you're going to have a complete right to left shunt. If you have TAPVR, you're going to have a complete right to left shunt because all your systemic venous return, all your pulmonary venous return, and your coronary venous return, they're all coming back to the right atrium as nothing is coming back to the left atrium. So the right atrium is packed and the left atrium is empty. So it's an obligatory right to left shunt in TAPVR. If you have a patient with like a massive vein of Galen or hepatic hemangioma, they're going to get tons of right atrial flow. So they're going to get a right to left atrial shunt. If you have PPHN or acute PH or CDH with high PVR, they can get a completely right to left shunt, but I'll be honest, most of the time they have a bidirectional PFO. It's rare that they have a completely strict right to left. So that's kind of like this information provides you a lot of information because then you can plug where's my RBC going. And if I have a huge volume of hypoxic blood from the right atrium entering my left atrium, well, by definition, your left atrium is going to have blue blood. So your left atrium can get blue blood in it in a normal heart, either because it has bad lungs, so the lungs are not doing its job, and the blood coming back to the left atrium is blue, so 60% sat because the lungs are collapsed, for example, or because you get a contribution of a right to left shunt at the atrial level. So if you have 60% saturation in your right atrium from the venous return, and you shunt a lot right to left, well, it's going to mix with what's happening in the LA, and it's going to drop your saturation in your LA, and so your preductal saturation will drop. Does that make sense? That's for a normal heart, obviously. So here, that's an example of PFOs that's left to right. These are tiny shunts. You want to measure it to see. So you see here it's 0.19 centimeter. You can even see the flap. When you see two nice ridge, it's unlikely to be a PFO. Or if you see more than one shunt, it's not a PFO. So these patients we need to follow, and we need to have cardiology to follow them to make sure that these shunts will close off at some point. So that's an example where you see nicely the interatrial shunt to measure it. And you can use this view nicely to view some of the catheter, although I like also the suprasternal view for some of these lines that are in the arms. So that's an example of a catheter in the SVC. You see the kind of hinge point of the right atrium, so of the tricuspid valve. So the tricuspid valve is here. And what you want is you want your catheter to be kind of at the SVC right atrial junction and not too much in your right atrium. So you see the catheter and you see your tricuspid valve. So it's like borderline, but it's within the SVC at the hinge point of your tricuspid valve. Okay. That's another example of a catheter, probably a bit too deep because this time you're kind of floating in your right atrium. So you can see the tip is here and your tricuspid valve is here. So I would have liked my tip here. Now be careful because if I measure here, it might give me a centimeter, but it might overestimate. So it's kind of the situation where I would not pull more than 0.5 and I would repeat my echo and then 0.5, repeat my echo. And at some point, if I pull more than one, I would want to do an X-ray. Part of the reason is that sometimes with ultrasound, you might overestimate some of these measurements and you may get some image of composition. This is the spine. So you see a catheter in the aorta. So that's the umbilical arterial line. And this is an example of catheter where you can get that view from the subcostal region. And you see kind of that catheter that starts entering your right atrium. So there's many examples on the website. You can see many examples of catheter. That's one of the view. We also will look in the parasternal views. We'll look in the views, kind of the suprasternal view, especially if you're looking at an SVC catheter or an upper limb catheter. Suprasternal, we have like 10 minutes, we'll see. The suprasternal is a great view to look at, like, for example, your ductal cut, to look at your pulmonary veins, to look at your arch, to look at the branching of your pulmonary arteries. So as we said before, you can get the classic, three vessel view where you see your SVC, aorta, and PA. You can also see your left atrium with your pulmonary veins entering. So that's classically called the crab view. You can see your SVC entering your right atrium if you're moving a bit your probe towards the right side. And you can see if you have eventually a catheter entering in your right atrium and the position of it. So as it said, the suprasternal view is typically over the sternum, but sometimes you can move it a bit to the right or a bit to the left, either to see your arch, to see the SVC, to see the pulmonary artery branching, or you can turn it 90 degrees to see the cross section of it. So here we're obtaining a cross section because we turn the probe 90 degrees like this. So when you turn 90 degrees, you really see the cross cut of your aorta. You don't see the aorta along its arch. So you would need to turn 90 degrees to see the actual arch. Okay, so that's what I mean to see the actual arch. So the cursor is towards the chin of the baby, versus if you turn 90 degrees and you have the cursor here, then you would get that cross-cut view. Okay, it's a good view also to get a sense if there's like signs of vascular ring in cardiology. So that's the view they would use. And that's the view that they use also to see the branching of the first vessel. So when you have this orientation of 90 degrees, typically you'll have to go a bit more towards the right shoulder because the aorta comes off from the right side of the heart and does a loop and then goes to the left side of the body. So that's why the ascending aorta is mostly oriented towards a bit the right side of the body because of this kind of looping that it does. And so typically we see the ascending, transverse aorta, descending, and that area is called the isthmus, which is the zone where the PDA will connect just under it here. Okay, so PE is here. And so in fetal life, you get ascending flow from the left ventricle, and you get flow from the ductus at the isthmus level, coming from the MPA into the descending aorta. So if you have, for any reason, a drop in your flow, in your output in your ascending aorta, this may lead to underdevelopment, eventually coarctation. So that's kind of, some of the mechanism of coarctation. Or hypoplastic arch. Okay, so it's good to see the color to make sure there's no acceleration. It's a good view to get your Doppler pre and eventually post ductal. So you need to see, is there a duct open? Is my duct, where is it connecting? And can I get some descending aorta Doppler? It's a good view to do ascending aorta Doppler. So for example, if you have aortic stenosis, it's a good view to estimate the gradient of the stenotic valve is from the ascending view. And you can get also Dopplers for some of the kind of branches of the aorta. So again, we have a right pulmonary artery in the middle. We have the ascending, transverse, and eventually descending arch. Your first vessel is typically the brachiocephalic arterial trunk. Then you get the left common carotid and then the left subclavian artery. Sometimes these two arteries are fused together, like almost you get a second trunk, but for the left side. And some people will call it the bovine arch, which is a bit of a misnomer because bovines don't have this vessel. They have a different arch configuration. So that's a bit wrong to call it that way. But people will often call it the common origin of the left common origin of the left carotid and left subclavian artery is probably the more correct term. And because they get this common origin, sometimes the arch will look smaller at that area by definition. So that's the example of a normal arch. You even see some thymus. You see nice flow, and you can do a CW to make sure there's no peak gradients above 15 to 20 millimeters of mercury. And then you can do your pulse wave Doppler to assess whether or not there's, like, for example, a postductal or preductal scale effect. So if a patient has severe LV dysfunction, that's a place where you want to see if your flow goes retrograde from the PDA into the ascending arch. So it's an important view for that, because then it tells you the entire perfusion of the arch is dependent on the PDA flow. That's an example of coarctation. So here you can see the ascending arch, and then you can appreciate that a bit of the transverse arch starts to lose caliber. And then here you get kind of this very, huge narrowing. You can even see it in like the ductal cut where you get a bit of the coarct that's very highly accelerated and turbulent, and you get this blue flow that feeds the lower body from the PDA. And these patients often also have something called a posterior shelf, which is that kind of triangle here. We, in French, we call it an éperon postérieur, if ever you need to write it. But this is called a posterior shelf in English, and it's thought to be potentially one of the mechanisms is thought that there might be some ductal tissue in there, and then when the duct starts closing, it constricts a bit this zone. So we'll measure, if you need to ever measure the arch, you want to measure in ascending, you want to measure the transverse, you want to measure the descending at the isthmus level, so the isthmus zone, or the descending postductal. These are normal Dopplers in a patient with no coarctation. So that's like the ascending arch. Okay, so you get these positive deflections because it's coming towards your probe. And then you can get, you'll need to believe me in that, but here there was the flow. And then we were able to obtain some flow at the postductal descending aorta. And you can see that you have forward flow in systole and then retrograde flow in diastole. So this patient had like a left to right PDA that was stealing. And just to show that when you were doing the arch before this PDA steal, because the arch goes like this and the flow goes like this, you can see that in the preductal territory, there's actually forward flow. So it's really, you confirm that this is a steal at the PDA level, and it's not a steal that happens from something above, for example, like aortic insufficiency or truncus arteriosus. Well, we know it's not a truncus in this case, like unlikely because of the duct, but like cerebral vascular malformation or vasodilation or other reason. So if you see retrograde flow, you want to make sure that your retrograde is actually coming from the source of what you think it is coming from and not from something else. That's another example where we did it from the suprasternal, but also from the subcostal. So from the subcostal, you can get your spine, you can get your descending aorta, and you can get the Doppler, and you can see clearly that there's retrograde flow in there. And then when we talk about the PDA, we'll discuss kind of these retrograde flow and all of the other vessels that we investigate when we investigate PDA physiology. Here it's from the suprasternal area where we get the descending aorta Doppler. So why would you have holodiastolic retrograde aortic flow? I've put a few reasons. There's many. Left to right shunt at the PDA, arterial trunk with truncus arteriosus. Sometimes we have something called the RPA from aorta, which is a variant. Aortoventricular tunnel, aortopulmonary window. If you have a BTT shunt, if you have a vein of Galen malformation with torrential flow, if you have cerebral venous malformation, arteriovenous malformation that are not vein of Galen, if you have a lot of aortic valve insufficiency, if you have aortopulmonary collaterals that are stealing a lot from your aorta, or if you have cerebral vasodilation. These are reasons why you could have holodiastolic retrograde flow. Then you can do your 90-degree and cross section. I think we've done this view together a few times, where you can follow your aorta. So this is the aorta in cross section. On top of it, you see kind of a bit of the innominate bridge. And then as you go, you start seeing that first vessel branching from the aorta. And eventually this branch, you can follow it here. As you sweep towards the right shoulder, it should divide in two. So 1 and 2. These are the two division. You've seen it. I go back together. Whoop, 1, and then divide it in 2. And that means that your arch is basically a left-sided arch. We even can continue and see the track of these two vessels. And that informs you that, you likely have a left-sided arch because it's going to branch the common, the brachiocephalic trunk divides towards the right side of the body to provide the right-sided subclavian and the right-sided common carotid. Here we've done it in 2D, so your vessel will split here. I'll redo it. Boom, the vessel, follow it, follow it, follow it, 1, 2. Okay. This is an example from the SVC. So we said you can do the 3-vessel view. So in the 3-vessel view, we have the SVC, we have the aorta, and on the side you have the PA. And so you can get to see if the SVC looks very dilated and looks torrential. And typically your SVC is not supposed to be the size of your aorta. It's supposed to be smaller. Typically you should have a PA that's bigger than your aorta, that's bigger than your SVC. And also like, look, this one has a Nyquist of 0.83 and we can see a lot of color, which tells you that these velocities are above 0.83. So there's a lot of velocity because there's a lot of flow coming into the SVC that has a maximal capacitance. This kid had a vein of Galen malformation. So it's one of the signs. This is a good view to then do 90-degree of that and then angulate more, towards anterior. Yeah. And then you can get what we call a crab view. And in this crab view, you can appreciate 1, 2 vein. So this is the right side of the patient. So we have the right upper, the right lower. And then you can even see nicely these 2 other ones, which are the left-sided ones. So left upper and then left lower here. And I want you to appreciate that the Nyquist was decreased a lot at 0.46 to see that. So if you have torrential flow through your lungs, you will see flow coming back nicely. Example is here, 93. This is a kid with like a lot of QPQS. So initially you might see very well your four pulmonary veins, one, two, three, and then you have four here. You can appreciate how the flow is significant, at least the velocities of them. And that's because obviously there's been a lot of QPQS. Okay. What's important is to then do the Dopplers. If you don't do a Doppler, it means nothing. Okay. So you want to see that these are triphasic, so 1 and 2 and 3, 1 and 2 and 3, or biphasic, because sometimes the first systolic waves will fuse, so 1 and 2. You don't want them to be at high velocities, okay? So you don't want them to be like, for example, above 1 meter per second. Why? Because if it's high velocity, it could tell you that you have a lot of QPQS and a lot of blood flow coming back from your pulmonary vasculature. And if you start losing the phasicity and it's just monophasic, it's you start being concerned for constriction. So, for example, a patient with pulmonary vein stenosis, and if you don't see any flow, it means you have pulmonary atresia, pulmonary vein atresia, pulmonary vein stenosis, and the critical aspect, the most extreme is pulmonary vein atresia. Okay, you can measure your S, your D wave. So often the D wave will start increasing when you have a very large left or right PDA because it will increase the flow during the diastole of the ventricle. So when the mitral valve opens, suddenly you get a gush of blood from that LA to the LV, and that vein is able to decompress after being exposed to an LA that had a closed mitral valve. So the velocity accelerates a lot. So that's one of the signs earlier on, but in time, whether or not these signs persist, it's difficult to tell because maybe also those veins adapt. So that's an example of pulmonary vein stenosis where you have a high Nyquist and you see this flow that's like almost continuous, looks like a flame. You see it at 2 level. So these, lower veins are definitely accelerated, and you see that they've lost this phasicity. It's like one block, one block, one block. They don't have these like 2, 3 bumps like like we've seen previously. And if you do the gradient, so you can do the gradient over 1 cardiac cycle or 2 cardiac cycle, basically you trace, and then you get what we want to see as a mean gradient. And mean gradients above 3 are definitely something that should raise suspicion for some degree of constriction. Here we have 8.7, and this patient had pulmonary vein stenosis. Okay, I see it's already 3 o'clock, so we're going to close it here. I have just 2 last views. I think you've seen this Pence view. We also call it the mustache view. So you remember how we said we have the 3-vessel view where we have the aorta, SVC, MPA. That's a perfect example where you see that the SVC is smaller than the aorta, that is smaller than the MPA. And the MPA divides in 2 branches usually. You get the RPA and the LPA. It's very classic to see that the LPA will be extremely tiny in babies with CVH. So that's one thing to look at. I don't know if you've noticed, but they've measured ASC, the American Society of Echo, measures the diameter when the pulmonary valve is open. So that's when you get flow through it. And technically, it's when they're the most expanded. So here you see nicely that the MPA is large, RPA is confluent, and you want to measure them when they're fully filled, not when they're underfilled, when the valve is closed, right? So you're waiting for the valve to be open or when they're at the most caliber, and you can measure your RPA. LPA, it's also a place you're going to do Dopplers. So if you have, for example, a large left or right shunt, this is a place you want to see, is there a diastolic flow in my RPA or LPA that is kind of fed by the PDA? It's a sign that the PDA might be kind of excessively feeding your pulmonary arteries. And that's what I mean by doing Doppler. So you can do Doppler. Here you see that there's almost no diastolic flow in this RPA or in this LPA. That's it. We're going to close this. I hope that was useful.
Yes, really.